So, good morning. It's my pleasure to have you all on the occasion of the World TB Day. Albeit it is on 24th of March, but nevertheless, we are meeting on the 30th of March within the financial year. So, thank you very much for everybody for joining. Before I start at the gathering, I would like to have some common rules and regulations for the virtual ethics. And what we can do is that we can keep ourselves on mute if we are not talking, and maybe we can post our questions also. There is a Q&A session specifically there, and that would be taken care after the speakers have finished their talks. So I would request if you have any question and answers during the sessions to put it on the Q&A session. You can see below on the taskbar, there is a Q&A session. So without further delay, I am going to request Dr. Aarti Nagarkar, the Director of the Department of Health Sciences, Pune University, Savitribai Phule Pune University, to address and welcome the gathering. Thank you.
Thank you so much. Good morning and very warm welcome to this webinar organized on the occasion of World TB Day, which, as Kunal mentioned, usually celebrated on 24th of March, but nonetheless, we are here together to commemorate this event. I'm very pleased to say that we are organizing this event with ICMR's National Institute of Virology, and I welcome Dr. Abraham and thank her for collaborating in organizing this event. I also welcome our eminent speakers, Dr. Shrikanth Tripathy and Dr. Aniruddha Kadu, who is right in the offline mode at the moment. I welcome both of them, and I encourage our students to have a dialogue with them and engage in a dialogue and communication so that you also give your contribution to this cause of investing in TB and save lives. Dr. Abraham, I would like to mention over here that ours is the first UGC supported department teaching public health in a traditional university system, in a non-medical system, we can say. And we impart skills in both laboratory as well as field-based activities relevant for public health to our students. And we encourage our students to do more research, public health research, so that they create evidence and they contribute somehow to have more relevant and better public health policies for better good. And therefore, these kind of events are very significant contribute to the teaching learning process in our system at the postgraduate level. And they not only help in growing students' knowledge, but also we are able to establish meaningful relationships or associations with the institutes. And I'm very happy that through this event, we are just beginning one more association with NIV. And I welcome you all once again. And thank you, Dr. Kunal, for putting efforts together and bringing all eminent speakers over here. I would encourage my students to pose their questions, and also afterwards, if after this seminar, if you have any doubts, question, we welcome all the speakers over here, and we will also look forward to have an opportunity to invite Dr. Abraham to Dr. Tripathi has been coming to the department, but sir, now you have shifted to Pune. We would like to invite you once again in the department, maybe next time. And without any further delay, I hand over and thank you once again. Thank you.
Thank you so much, Aarti ma'am. And now I would request the woman with the mission, the multifaceted, the one and only our director, Professor Priya Abraham. Ma'am is an eminent scientist. She is a teacher and she is a mentor. And one of the mentee, I hope I am also one of them. And I will request ma'am to share her view. She is now also taking care of NARI as a director. So she's balancing the efforts. And I personally feel that women in her capability is the suitable one to balance this effort. If I am said to do, it's impossible for me to handle. Over to you, ma'am, to address the gathering on the occasion of the World TB Day. Thank you. Ma'am, you are on mute.
Yes, yeah. Thank you very much, Dr. Pise, for those very gracious comments. And thank you, Dr. Nagarkar, who you have given us a very nice introduction to the School of Health Sciences at the Savitribai Phule Pune University. And I'm really privileged to be partaking of this event today because your School of Health Sciences really seems to be a trailblazer in its league. And I'm delighted that we also have two very eminent speakers who have joined today's deliberations. We have Dr. Shrikanth Tripathy, who was former director of the National Institute of Research on Tuberculosis at Chennai. It's another ICMR institute that is steeped in history, done wonderful work in the field of tuberculosis. Currently, he is also the Director of Medical Research at the D.Y. Patil University in Pune. I think D.Y. Patil University is privileged to have him join as their Medical Research Director. We also have a very another eminent speaker, Dr. Aniruddha Kadu, who is the WHO National Tuberculosis Elimination Program representative. And I think today we are going to have a feast of two stalwarts in the field of tuberculosis. I would addressing all three of you and also other faculty from the School of Health Sciences, my dear colleague, Dr. Pise, other colleagues from National Institute of Virology, with whom I work very, very closely. I'm really happy to be here on this occasion. Now, we are here to actually commemorate the World Tuberculosis Day and to make an impact of any kind for the cause that we are going to deliberate on, we need to plan and start early. And what would that be? So we are here to start early, having many of the youths who are logged in today listen to this important topic of tuberculosis, which is a very relevant and germane topic for our country. Yeah. TB, as you know, has had a devastating impact on health, social and economic fronts. And every year, usually, we remember and use it as an occasion to spread awareness of TB on March 24th. Unfortunately, this year we couldn't do it on that day. But as Dr. Pise said, we're just 6 days away from that day within the same financial year. And why March 24th is chosen is because it was on this day that Robert Koch announced to the world that TB was caused by a particular bacterium, namely Mycobacterium tuberculosis. This opened the whole avenue of research and diagnostics to understand more about this disease, to diagnose it in time, to treat it in time, and make definite efforts towards eliminating it. But the challenges have been several. Many of the low and middle income countries still grapple with this disease. And as the world and as WHO has given us a mandate and the world has oriented to eliminating TB by 2030, we in our country have actually set ourselves a tougher target. We have actually used 2025 to achieve this goal. And in a country as complex and heterogeneous as ours, it is indeed a challenge. TB remains one of the most deadliest infectious diseases, and our efforts towards elimination actually received a huge setback in the context of the current pandemic. And it led to enhanced mortality due to TB, particularly in the year 2020. Though it's a preventable disease, globally, each year, around 5,000 people fall ill, and we lose at least 250 to this disease. It's a huge loss to mankind in this day and time. And the problem has been compounded by two other facets that TB often is a co-infection along with HIV infection, which makes it more complex. And we also know that today we are battling multi-drug resistant tuberculosis. So So these are two other challenges to our efforts to eliminate this disease. So on World TB Day, as of this year, the theme that is chosen is to invest to end TB and save lives. When we say invest to end TB, it means investment in the form of resources to accelerate the fight against TB, investment in sustained commitments from the global and national leaders. Fortunately, our Prime Minister is very, very clear that our deadline is the year 2025. Investment in the technical advancement for drug resistance, in methods to diagnose it, investment to ensure equitable access for prevention and cure of TB, and finally, last but not the least, investment in you being the youth of our country, to take part in enhancing the awareness generation of this deadly communicable disease. So with these few words, I would like to wish this program the very best. I hope the young people that are tuned into this program will imbibe all of what our speakers are going to deliver and would volunteer to be active ambassadors of increasing the awareness about this disease so that we can work very purposefully towards the elimination of tuberculosis. Thank you all for inviting me to this very important function, of which we should all be very much engaged with. Thank you.
Thank you so much, ma'am, for the words of wisdom. And thank you. You are saying that investment in the youth, no? So I consider ourselves also to be youth.
Yes.
So we all are investing ourselves through capacity building and through learning and by doing and many other things. So thank you so much for that words of wisdom. And I would take another, and please lend me another 1 or 2 minutes to introduce our eminent speaker, Dr. Shrikanth Tripathy. Sir had sent me a CV. I had to concise it. It was a good Herculean task for me. So please lend me 1 minute to introduce our next important speaker. I would like to introduce Dr. Shrikanth Tripathy, sir. I personally feel he is a unique blend of a clinician and a hardcore laboratory scientist. And it's really surprising, like for me. He has over 160 publications in journals relevant and has been involved in around 23 research projects. Sir had ICMR in 1986 and was there till 2020. He has to his credit being important achievements like the subtypings of HIV into CA and B, development of HIV virus bank at NIRT, the use of ART in HIV, the drug resistance pattern. He also helped establish the HIV-1 drug resistant laboratory at NIRT. His studies helped to formulate the NACO guideline for prevention of HIV transmissions from HIV-infected mother to their children using a safe 3 drugs ART regime in HIV-positive women. He was the director of NIRT from 2015 to 20 and helped to initiate the VPM-1002 vaccine study for the prevention of TB in household contacts for TB cases in Chennai region, and also was instrumental in the TB prevalence study from 2017 to 20. The results are now out. He also helped evaluate the TrueNat real-time PCR assay for the diagnosis of tuberculosis, and the results of the study helped to assess to be taken by the government of India for the diagnosis of TB by the Central TB Division of India. And he was also an investigator in the National Sero Survey for the COVID carried out by ICMR in 2020. After his retirement, he has joined as the Director of Medical Research at D.Y. Patil University, and I welcome him and request him to deliver his talk. Over to you, sir. Thank you.
Thank you for the kind introduction, and thank you to Dr. Aarti Nagarkar and Dr. Priya for giving me this opportunity to share my thoughts on this commemorate the World TB Day. So with that the background, I'll go ahead and start my presentation. Is my screen visible?
Yes, sir.
Yes, sir.
Yes.
So the government of India brought out a document on the National Strategic Plan for TB elimination for the years 2017 to 2025. The target was to eliminate TB by 2025. And there was very strong political commitment, and Honorable Prime Minister of India, in his Man Ki Baat radio address to the nation on 27th of March 2016, Shri Narendra Modi ji ne bataya कि we have to defeat TB in India. And that was the mandate given to us, that we have to make all efforts to control TB by 2025. Subsequently, on 24th March 2017, Shri J.P. Nadda ji, Honorable Union Minister for Health and Family Welfare, he did mention that he encouraged and invited all to join in the journey towards a TB-free India and a healthy future for all our people. With that in the background, let us look at the incidence of TB in our country as per the Global TB Report of 2021. What we see here is that the incidence of TB has been falling from around 250 in the year 2010. It has gradually been reducing, and currently it's estimated it's around 188 per lakh population. And if you look at the number of drug-sensitive TB cases which have been notified in our country, if you look at the data here, what we see is that if you see the data from 2020, what we see is that there has been a decrease in the number of cases in around 2020. And then again, the number has increased. So you see here, this was the effect of the COVID pandemic in our country. The number of cases went down in 2020. And 2019, the numbers were much better. 2021 also it's good. But in 2020, the numbers were low. But again, the numbers towards the end of 2020, numbers of drug-sensitive TB detected have been increasing. But drug-resistant TB, if you look at it, in 2010, the facilities available for detection of drug-resistant TB were not that good. And in 2010, what happened was the WHO recognized the CBNAT test or the GenExpert test, which was used for rapid detection of TB using the molecular techniques. And within about an hour, we can give the result whether the patient has TB bacilli in the sputum or not. So that was a tremendous advantage for detection. Not only did it detect TB, but it also gave us evidence whether this patient had rifampicin resistant TB. And that was a very big advantage again. It told us, gave us an indication whether this patient was like the. But subsequently, what we see here, the number of cases of MDR-TB detected has been gradually increasing. And by 2019, it reached a peak of almost more than 56,000. But subsequently, what happened was the COVID pandemic set in, and then the number of cases reduced in 2020. But again, it seems to have increasing at present. So hopefully it will stabilize once again, and we will be able to detect as many as possible of the drug-resistant TB cases in our country. And it is heartening to know that after the year 2015, several clinical trials have been done on management of drug-resistant TB, and new drugs for treatment of drug-resistant TB have been introduced, both for MDR-TB and XDR-TB. New drugs have been introduced in our country. And previously, management of MDR-TB or XDR-TB was very difficult. Mortality was very high. But today, with the excellent regimens that are available, if we detect these cases early, it is possible to have very good results, and we can save them. If you look at the mortality in all forms, in our country, there has been gradual decrease in the mortality in TB cases over the years from 2010 to 2019. But what we see here is there is a slight increase. This increase has been seen not only in our country, but it has been seen globally as well, all over the world. So there has been, because of this pandemic, COVID pandemic, the access to healthcare because of the lockdowns was difficult. And due to that, the access to treatment also was difficult. And then there has been a slight increase in the mortality. Hopefully, with the pandemic abating, we should have the mortality once again starting to reduce. This is something which we have to definitely have a close look at. This is the healthcare facilities which are available in the laboratory sector. We have 6 national reference laboratories, and these national reference laboratories are equipped with all the possible tests that we can do for detection of TB, including microscopy, molecular tests, the line probe assay, the liquid cultures, the solid cultures, as well as liquid culture DST test. So you see here, they have a whole battery of tests, and these 6 centers also have access to full genome sequencing of the MTB vessels. And we have 4 integrity reference laboratories at the state level, where they have access again to most of the investigations. And then at the medical colleges and in the private sector, the culture and DST laboratories facilities are available in 58 labs, where microscopy, CBNAT, LPA, liquid culture, and liquid culture DST, that is drug sensitivity testing, is available. Rapid testing is available, either GenExpert or TrueNAT, and microscopy is also available. Microscopy by fluorescence microscopy or ZN staining. And then at the district level, we have 21,820 direct microscopy centers, where also we have TrueNAT and CPNAT available for detection of TB. Now, the National Strategic Plan for TB elimination, the vision is to have TB-free India with 0 deaths, disease, and poverty due to TB. So this is the vision. And with this, the goal is to achieve a rapid decline in the burden of TB morbidity, mortality, while working towards elimination of TB by 2025. And if you look at the goals that the NSP has set for us, by 2025, the target is to reduce the TB incidence rate to 44 per lakh population. The prevalence, TB prevalence, the target is to reach 65 per lakh population. To reduce the mortality to 3 per lakh population. And also to reduce the catastrophic expenditure cost to 0% for the families of TB affected patients. And if you look at the outcome indicators, the TB notification targets are that we should detect almost at least 3 million cases by 2023. And hopefully the numbers will come down significantly by 2025. For this, a determined effort has to be made to detect all these cases, put them on treatment, and cure them before they infect others. So early detection is very crucial. Then what the MDR TB patient notified, the numbers should be detected as early as possible. And the DST testing, what we are aiming for, 100% of TB patients should be tested for drug resistant by 2025. And the proportions initiated on anti-TB treatment by 2025, we are targeting 95% of the notified TB cases will be initiated on TB treatment. And the success rate for the TB treatment, again, we are targeting at least 92% will be successfully treated by the year 2025. And then in drug-resistant TB, the success rates are a little less, but still with the regimens that we have currently available, if so properly implemented, the mortality can be reduced to less than 25%. Then the active case finding in the high-risk population, we are targeting 100% by 2025. And direct benefit transfers for patients to help them to overcome malnutrition or giving them access to insurance and other monetary facilities, benefits to help them to receive proper treatment. We are targeting again 95%. And also, in those who are eligible for TB preventive therapy, at least 95% should be started on TB preventive therapy. Now, so what are the various components in the National Strategic Plan for TB elimination? The first point is detection. We have to detect all the drug-sensitive TB cases and the drug-resistant TB cases, with an emphasis to reaching out to all these patients seeking care, both in the private sector and in the government sector. A significant proportion of the patients go to the private sector for treatment of TB. And hence, the government has reached out to the private sector in a significant way. And now all doctors are aware that their patients can have access to the best possible diagnostic facilities and treatment facilities from the government healthcare facilities, while the patient is continuing to attend at the private sector as well. So high sensitivity diagnostic tests are available to even to the patients in the private sector, and universal testing for drug resistance is done for all these patients, and systematic screening of high-risk populations also has been initiated to detect these TB cases. Now, after detection of the TB cases, the next activity to be done is to treat these cases. So we have to initiate treatment, appropriate treatment in these patients who are detected. Then they should be followed up to ensure that the treatment that they take their treatment regularly, and all the drugs are available free in the program, both for drug-sensitive TB as well as drug-resistant TB. And excellent regimens have been included in the government program, and these drugs are available to private patients as well in the private sector. And adherence monitoring is done closely by the TB program to ensure that all patients continue the treatment regularly and get cured. The best possible chances for cure is given to them. And catastrophic costs can be eliminated by ensuring that all facilities are provided to patients so that the patient doesn't have to spend much from the pocket. The aim is to have nil expenditure from the patient for TB treatment. And then the third point, which the program has implemented, is to prevent TB. Prevent the emergence of TB in susceptible population. And how do we do that? Airborne infection control measures are implemented in the healthcare facilities. Then latent infection can be tested in the context of bacteriology confirmed cases. and individuals at high risk for getting TB disease. And those who have latent TB infection, they are provided preventive therapy. And also social determinants of TB are also addressed through an intersectoral approach. Now, the last component in the NSP is the build. That is, we build and strengthen policies to empower institutions to build human resources and enhance capacities of the various organizations associated with the TB program. Also to improve the financial resources to ensure that the program is successful. A high-level political commitment is there both at the central level as well as in the state level. And the RNTCP management structure, the health resources or the human resources are substantially augmented by providing a suitable, adequate number of staff, trained staff to the program. Then technical assistance is provided both at the national level and state level to the TB program. And the partners activities, that is the NGOs and the patient organization, TB patient organizations, their activities are harmonized with the program to ensure that there is no duplication in the activities. Now, the TB program's focus to increase the result of TB control. In the one main factor which has been happening so far in the past, where that significant proportion of TB patients were being missed out from the government TB program because they were going to the private sector, and we had no idea what was happening in the private sector. Government did realize this, and soon they linked up with the private sector. The RNTCP has linked up with the private sector in a major way to ensure that the service and monitoring of the TB patients is jointly done both by the private sector and the government sector. And the benefits of the program are available now even to the patients in the private sector. Now, collaboration between national programs and various departments and ministries are also being done with the TB program to ensure that more efficient coverage is done and that the goal of TB elimination is met. Research has been instrumental in ensuring that better drugs are available for treatment of TB patients, and also better diagnostic facilities are available, and also preventive measures can be put in place. In fact, as far as prevention research is concerned, there is one very big vaccine study, VPM 1002 vaccine trial, which has been going on last few years, and it will be completed by next year. And we will have the knowledge whether we have a better vaccine than what we are using in the program right now. In the program, we are using BCG, but we are hopeful that we'll have a better vaccine for TB prevention soon. And strategic resource mobilization for mobilizing funds, in addition to what the government is providing, more resources are being mobilized. Then there is TB patients are being closely interacted with by the government program to ensure community feedback mechanism to improve the TB control efforts. And also at the global level also, India is interacting with the global TB arena, including the WHO. And the critical components of the program is one is that the patients seeking care in the private sector are also included by involving the private doctors and the patients so that they can report the cases to the program and take the benefit of the free treatment with being provided by the program. Not only the treatment, but also the cost of the investigation that is provided free to these patients. Then there is a data management system to monitor the patients who are detected and treated. And this is the Linkage system, which is available all over the country. And it gives excellent data to the program to see where the problem is more and where more resources are required for control of TB. The National TB Prevalence Survey also gave us data on where the extent of the problem is more, where more resources need to be put in for control of TB in our country. Which are the states, which are the districts where the problem is more. And the rapid molecular tests are made available to all patients, both in the private sector and in the government sector, so that adequate treatment can be given early. The molecular tests are rapid, help to give a very early detection of TB. And so all patients, if they have any evidence of cough or fever, weight loss, they go to the sector, to either the private or the government sector, they have access to these molecular tests for early detection of TB. Adherence, the government has ensured that a system is put into place where SMS services are given to the TB patients to remind them to consume their drugs. Now it is a daily regimen which is being given. So every day the patients are reminded to consume their drugs. Nutritional support is being provided to TB patients, and also incentives are given to states who are doing well. Awards are being given, and this information is available to all, so that it will encourage other states also to do well. And there's a TB Corpus Fund, which has been created to accelerate TB control efforts. And the activities like nutritional support to TB patients, active case finding in prisons, slums, tribal areas, sputum collection and transport in difficult areas are being efficiently carried out now to detect the cases and ensure all are put on treatment. So if we use this formula, that is detect, treat, prevent, and build, the significant the targets which are given by the NSP are reachable, but this requires a lot of funds, and hence NSP has put in 12,327 crores in the national TB programs, and this is required. This large expenditure is required because not only in the government program, but this TB patients in the private sector also need to be treated. And this requires follow-up of the patients. And even after they are completing their treatment, follow-up has to be done to ensure that if there is a relapse, they are treated properly. So as far as the detection of TB is concerned, in the NSP, what does it mean for TB elimination in India? It involves early detection of presumptive TB cases at the first point of care, either in the private sector or in the public sector. And for this, high efficiency diagnostic tools are required. And that is why the government, initially, we were using only smear AFP for detection of TB cases. But nowadays, we use the molecular methods. We have two different diagnostic tests which are available, the GenExpert and also the TrueNat, which help us early detection of TB. Then we have also the active case finding efforts, which are done all over the country in high-risk groups. And also the quality of the free diagnosis and treatment is of high quality and is given free to all the patients, so that these patients can be detected early and put on treatment early before they transmit infection in the community. And the laboratories of what are the tests available, and this gives a list of all the tests available in our TB laboratories all over the country. We have immunofluorescence microscopy, we have solid culture for MTB, we have liquid cultures, and liquid cultures can be used for drug resistant testing as well. And the line probe assay, the CBNAT assay, and the private sector is also in can access all these investigations. So these investigations are available for both private and the government sector patients. Active case finding, there are different vulnerable populations which have been identified in the urban areas, the rural areas, and in the tribal areas. These are all the list of vulnerable populations in each of these areas, and government is targeting this population for active case finding to detect the cases early, so to reach the target of 2025. In the private sector, all the patients who are detected are notified by the private sector to the government as well. And in the process, the private sector patients have access to both the diagnostic facilities and also the drugs treatment services from the government sector. And the patient support is also provided in the private sector as well. And then in the process, a strong surveillance system has been established, and also the quality of management and care provided to the TB patients has improved. And as far as treatment is concerned, we in the NSP, the target is to provide sustained equitable access to high quality TB treatment. And to ensure the high quality TB treatment, every batch of drugs which are used are sent to the laboratory for evaluation of the drug content, and only if it passes the quality control test, then only it is used in the program. So every batch which is used in the program, the quality is assured. And the treatment, all drugs are provided free, and also the access to the care of these patients is ensured both in the private sector and the government sector and the government sector. And the patient's feedback also is taken to ensure that the quality of care can be improved both in the private sector and the government sector. Several NGOs have been involved in providing this treatment as providing support to the government program to ensure that the patients from the private sector are treated properly and are part of the TB program in India. Now, the government has instituted several mechanisms to help the TB patients. The notification of TB patient both in the private and the public sector, provision of free treatment, the best possible treatment for TB patients is provided. The nutritional support also is provided, and adherence support is provided to the TB patient to ensure that they get cured. Then they are linked up with social protection schemes, and after they have been fully treated and cured, there's a follow-up also being done to, in case they relapse, they are picked up early and then again investigated, look for drug resistance, and they're put back on treatment if they have developed relapse. Now, the vulnerable populations for TB, there are three categories of patients. Patients who have increased exposure to TB where they live or work, example, prisoners, sex workers, slum dwellers, minors, healthcare workers, factory workers, construction workers, community health workers. Because they live in close communities, and if one of them gets infected, they transmit the infection to others, and others can come down with disease as well. Then people who have limited access to quality TB services, like for example, migrant workers, or children, geriatric populations, tribals, and those who are living in hard-to-reach areas, or refugees, illegal minors. So these are some of those who are having limited access to quality TB care. So more work is required to see how the TB treatment can reach them. Then we have people who are at increased risk of TB. HIV, we know very well, are at increased risk of TB if their HIV is uncontrolled. Similarly, diabetes, silicosis, those who are undergoing immunosuppressive therapy, especially for malignancies, those who are undernourished, those who are tobacco users or alcohol, have alcohol use disorders, and those who inject drugs. These are individuals who are at increased risk of TB. And these also need to be targeted for early detection of TB and prevention of TB if possible. Now, as far as TB is concerned, there are the distribution of TB in the country. The various regions have been classified as high TB areas, and those they are category A. Category B, where there is high TB and HIV. Category C, where there is high drug-resistant TB. And category D districts are those where very low case-finding efforts have been made, where annual TB suspect examination rate of less than 400 per lakh population. And then E, where none of the above are there. And F, where they have a very low case-finding notification. Though they are doing a good job of examining a large number of individuals, more than 1,200 per lakh population. But the case detection is very low because of the low TB prevalence in that area. Now, as far as strategic intervention are concerned, several methods have been implemented. Collaborative framework for TB with diabetes, tobacco use, and alcohol consumption. So these groups are identified and provide screening for TB in these vulnerable groups. And TB also collaborates with National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases, Stroke, and National Tobacco Control Program, where screening for TB patients are being done. And strategic intervention is also linkage with other national health programs, like the National Tobacco Control Program, NGOs working with the International Organization for Migration, and then the National Program for Non-Communicable Diseases, those with occupational risk, such as silicosis. These are patients who are persons who are predisposed to TB. So, Ministry of Labor interacts with the TB program for this. The Rail Travel Ministry also interacts with the TB program. And the proposed interventions are there is a bidirectional screening for TB and diabetes. So diabetes patients are screened for TB and TB patients are screened for diabetes. And then those who are using tobacco, they have access to the program to control their smoking habits. Then the smoke-free healthcare facilities are provided to ensure that patients are having the best facilities for treatment. Then linkage of all current tobacco alcohol addicts to de-addiction clinics, and treatment support counselors are appointed for providing the best possible support to the TB patients. Now, sir, in the Nikshay program, we have the DBT or the direct benefit transfer of the money that is given to patients to help with their treatment and for their nutrition and for their insurance care. And also, they are also each TB patient is asked to open an account, and the DBT is the amount which is given to the patients for their health care, for their nutrition, and also the monetary benefit given for accessing their program and taking their treatment regularly, that is directly transferred to the patient's account. In the process, a lot of TB patients have now opened bank accounts. They have learned how to operate a bank account, and social welfare schemes have been made for the TB patients. And also there are some schemes which have been linked up with the TB program to help TB patients when they require help. Now, as far as catastrophic treatment is cost for patients is concerned, the patient has been provided as much benefit as possible Like, for example, the diagnosis and treatment is made free for the patient. The program gives everything free. Then travel, again, the program has given vouchers so that they can travel using the government, either train or by bus. They can travel free and come to the centers for treatment. Nutritional support, monetary benefit is given to improve their nutritional support and also to cover up for their wage loss. So this process should decrease the catastrophic cost to patients in a significant way. As far as prevention of TB is concerned, what does it mean? We have to ensure that airborne infection control measures are there in the healthcare facilities to prevent transmission from the infected patient to the other patients in the hospital setting. And treatment of latent infection in contacts of bacteriologically confirmed TB cases, and also to address the social determinants of TB through the intersectoral approach. Now, there are certain challenges for the prevention. The cough etiquettes need to be followed. Spitting needs to be avoided. Indiscriminate spitting. If patients have to spit, proper provision is provided where they can spit, and they are asked to collect the sputum in certain spittoons, which is sterilized at the end of the day. And sneezing or coughing without covering the face. Alcoholics are mentally challenged patients, and convincing them to follow the guidelines may be difficult. And there may be some migrant populations or backward areas and tribal pockets where it may be difficult to the healthcare facilities to reach. So the government is making all efforts to ensure that even they are having access to the TB program. And delay in diagnosis in comorbid conditions like diabetes, HIV, cancers can also lead to transmission of TB in the community. So early detection of diabetes, early detection of HIV, and early detection of cancer are beneficial in controlling these and prevent TB in these individuals. So smoking, indoor air pollutions also are risk factors for TB. And hence, these need to be addressed as well to ensure that TB can be prevented. At the institutional level, in the outpatient facilities, the patients with chest infection, they should be attended to first so that they do not infect other patients nearby. Overcrowding should be avoided as far as possible. Poor ventilation should be avoided. And wherever possible, this should be addressed. And in the inpatient facilities, patients who are having cough, they should be screened and as far as possible separated from other patients and given masks so that they don't infect the nearby patients. Infectious patients should be, as far as possible, kept in the infectious ward. And cough etiquettes need to be followed by them. Overcrowding in wards also need to be avoided to prevent transmission in the ward setting. In the ICU also, there should be adequate procedures in place to prevent transmission of infection from those who are coughing. And daily reporting of diagnosed patient details to higher centers to ensure that proper measures are in place to control the infection. Then for controlling the infection, proper facilities need to be provided in the health facilities for preventing airborne infection. Proper cough corners or counters need to be provided. N95 masks to hospital staff who are working in high-risk settings. And then there should be proper infection control measures in place. And a follow-up of daily reported cases need to be done properly. Early disposal of sputum and infected materials need to be done properly. And early diagnosis and initiation of treatment of TB patient to prevent transmission of TB in the community. Proper PPE to the staff where needed. Wet mopping and disinfection where required. Periodic screening of the staff who are working with the TB patients once a year would be ideal, and proper ventilation of the facilities, healthcare facilities, and periodic training of the staff to ensure that they are following all the precautions needed to prevent transmission of infection. Now, as far as TB prevention concerned, in household contacts, every infectious TB patient, they need to be screened for symptoms. If they're symptomatic, they have to be investigated and by both X-ray and sputum examination. In extrapulmonary TB, chest X-ray has to be done to see for pulmonary TB, because pulmonary TB is coexisting with extrapulmonary TB. Then they are infectious to others and to their close contacts, and the close contacts need to be screened for TB. And if they are having symptoms of TB, then they have to be tested by X-ray and sputum examination. And INS preventive therapy is given to all children who are less than 5 years of age, and those who are staying in the same house of a sputum smear positive TB case. And if the children are examined by a pediatrician, if there is no evidence of TB, then after excluding active TB, the child can be given INS preventive therapy. The dosage given is 10 milligram per day for a minimum period of 6 months and maximum period of 9 months. But during this therapy, sometimes toxicity due to INS can occur. One needs to watch out for that. Isoniazid preventive therapy can also be given for HIV positive patients when they are starting on ART therapy, because some of them could develop TB at the time they are being initiated on ART. And also children living with HIV, they're more than 12 months of age, and they don't have any symptoms of active TB, and they have no history of contact with the active TB case, then they can be given INS preventive therapy for a period of 6 months. And also, as far as the build component of the NSP is concerned, it involves ensuring that we build synergies with the healthcare service delivery mechanism in the urban health mission and plan for integration of services. And we have adequate human resources in place in the TB program to ensure that the program is implemented and adequately, and strengthen the RNTCP's capacity to control the TB drugs through proper laws, regulations, and policies. Here, the RNTCP is closely monitoring even the drugs which are dispensed in the pharmacies, private pharmacies. Everything is monitored, and in the process, the program comes to know, even if the patient is collecting drugs on the private sector, the program comes to know about this, which patients are taking these drugs. Also, this helps to position TB high on the health and development agenda of the nation to ensure there are adequate resources and universal access to TB care services. I think I'll stop there. So in brief, I'd like to conclude by saying that if people in our country are to be productive, then they need to be healthy, both physically and mentally. If they are to be healthy, then adequate healthcare services are required. And TB was one of the most common causes of morbidity and mortality in our country. So now the TB program has put in place a mechanism by which we can detect the cases, treat the cases, can prevent the cases. So it's now the mechanism is available. We need to identify TB cases, ensure they are put on treatment, and ensure that they do not transmit the infection to their surrounding citizens, and also ensure they get cured. And after cure, they need to be followed up at least for 2 years to ensure that they don't relapse. If the program is implemented efficiently, I think we are well on our way to reach our targets by 2025. Thank you.
Yeah. Thank you so much, sir, for the words of wisdom. So there are few questions, sir, and I would especially like to take one which have physically come here, apart from those which are there are populated on virtual platform. I could just one or two questions have come physically to me, and they are very interesting, and I couldn't stop myself from taking that up, though it is at the end of the session of Dr. Kadu, but with due request to Dr. Kadu, I'll just take these two questions from the department that has come up. Sir, okay, okay. Sir, can you stop the screen sharing so that we, yeah. So the first question to the panelist here is, what were the reasons for increase in the incidence of TB from 2015? So I'll just open this for yourself, Dr. Shrikanth Tripathy, sir, and Dr. Kadu to answer it. So would you like to take it up, sir?
No, the incidence has been gradually decreasing. So till it has not been increasing; it has been decreasing. So the number of cases detected has been new cases detected has been decreasing. But you know, in 2019, there was a drop in the number of cases detected, sudden drop, almost 60. It fell to about 1.6 million. I think that was probably the due to the COVID pandemic. So people during lockdown they have less access to healthcare facilities. So there was a drop, but again after that 2020 again the number has gone up. So during that lockdown period there was a decrease in the number of cases detected, but it has again. So you see here, when the program is efficiently implemented, there will be a number of cases detected will be more. So it is bound to happen. But as the time goes, the number of cases will again come down. So last 2019, because of the COVID pandemic, there has been some difficulty in patients accessing the healthcare facility. But currently, the situation is much better. So I'm sure this year the program will do much better because patients will be readily able to come to the facilities. The transport will be easier. During the lockdown period, transport was very difficult for patients to come to the hospital. You know very well what happened. So all travel was restricted due to the lockdowns. But now the COVID prevalence has come down significantly. Hopefully it will remain like this, but we should take advantage of the situation and ensure that the TB program is implemented very efficiently now, so that we are well on our way to reach our targets for 2025. Because we want to reduce our morbidity and mortality, and also the incidence of cases and the prevalence of cases. All these we want to ensure. The target is to reduce the mortality to 3 per 1 lakh, and also to reduce the incidence to 44 per lakh, and the prevalence to 65 per lakh by 2025. So if I sincerely hope if we don't have any major pandemic of COVID once again, if that does not happen, I think the situation looks good for the TB program, because everything is in place. Our laboratories are in place. The machinery for providing the free treatment is in place. The linkage with the private sector is in place. The the benefits to the patients, that is also being given directly to the patient's account, so that patient has access to some money for buying their nutrition and also for their daily needs. And the travel also is made free for them, so they can come and go without any expenditure in their pocket. And the best part is that the active case finding also has been initiated. But in the tribal areas, in the hard to reach areas, I think government has instituted programs to make sure, but then the tribals need to take advantage of the facility. So the knowledge among the tribals needs to be improved. But I'm aware that there are some customs in the tribal population, like alcohol intake. That is something, a custom in some of the tribal areas. And what we found was, if we try to dissuade them from taking alcohol, then they stop the treatment. They would rather just continue the alcohol and stop the treatment. And especially we found this in the Sahara population. It is a custom for them to take the alcohol. And when the program people started trying to dissuade them from taking alcohol, they stopped taking the treatment. So sometimes we have to study the local population, what their habits are, and see how to implement the program in the best possible way, without compromising the adherence. The patients have to continue to take the treatment regularly. Otherwise, they will not get cured. If they don't take treatment haphazardly, then chances of drug resistance goes up. So we need to ensure that we have to ensure adherence to treatment. But as we say, the number of cases going up, that question you mentioned, and the private sectors got involved with the government sector, then this combination, then more data started pouring in from the private sector. So the numbers started going up. Numbers detected, because we had the government sector, it's estimated that about 1.8 million are the government sector, another 1 million in the private sector. So till about 2015 or 14, the private sector was not really taking part in the government program in a big way. But now we have that data also coming in. And that is resulting in the numbers going up. It is a good sign. It's a sign that the private sector has faith in the government machinery. They are willing to utilize the investigation from the government sector. They are willing to also take the tablets from the government sector and provide to the patients. Because previously the private sector had a apprehension that the government sector, they will take away their patients from them. But government has put forth a nice mechanism where the patient can continue to come to the private sector. The only thing is their samples are taken from there and sent to the government laboratories, government approved laboratories for testing. And the report goes back to the private doctor. And then the tablets also are given to the private doctor to distribute to the patient, free treatment. The only information the government sector wants is whatever they do for the patient, they have to report back to the government. So the private sector data is also pouring into the system now. So the numbers are going up. That's a good thing, because we estimate that close to about 3 million TB cases occur every year in our country. And as more and more private sector patients are reported to the government, the numbers are only going to increase. But this COVID has definitely made things difficult when during the period of lockdown. But with the lockdown being lifted, I think things are better now.
Yes, sir. Thank you so much, sir. And actually, you have kindled my love for the statistics and data and reading through the data. The initial slides, actually, I remember my days with that. Thank you so much, sir. In the interest of time, sir, we will be posting the questions at the end of session of Dr. Kadu. And I would like to introduce our new speakers, that is Dr. Aniruddha Kadu. Dr. Aniruddha Kadu is the state headquarter consultant for WHO-NTEP in Maharashtra. He is a public health professional with more than 11 years of experience in the field of public health and research. He has done his MD in community medicine. He has played an instrumental role in designing and implementation of the quality assurance programs for Government of Maharashtra for providing standard and sustainable qualities for RCS services across public health facilities. Presently, he is working with the WHO as a tuberculosis consultant for the implementation of the National Tuberculosis Elimination Program since last 8 years. During his tenure with WHO, apart from strengthening of the routine program activities, he has assisted the government of Bihar for devising innovative strategies for TB eliminations, like piloting the ICT-based 99 dots technology. It's a low-cost technology for monitoring and improving adherence, as Dr. Tripathy had mentioned about the improving in adherence. So one of them was being piloted by him. The universal access to TB care for engaging private sector, the intensified case finding in high-risk group for reaching the unreached, the upskilling of the new diagnostic techniques and others. And then he is posted with Government of Maharashtra here for implementation of the National Strategic Planning for 2017 to 25 for TB elimination, which included the rollout of the daily regime of the drugs for the drug sensitive TB patients, the universal DST, and the DST guided shorter treatment for the drug resistant TB patients. Also, he was a part of strategic engagement of the private sector in the NTEP program. He has also supported the government of Maharashtra in the recent COVID-19 pandemic response. So thank you, Dr. Aniruddha, for gracing this occasion and consenting to be a subject expert for the session. I would request you to please throw some light on this year's themes and your opinion about how TB elimination is a possibility in our country. Thank you. Over to you.
Thank you, Dr. Kunal. So, first of all, I would like to thank Dr. Aarti Madam, Dr. Priya Madam, Dr. Kunal, and the whole team of School of Health Sciences, Pune University, for inviting me for this talk in front of this August gathering. So, excellent. Also, I would like to congratulate Dr. Tripathy sir for excellent talk. He has covered almost everything. All the doubts. I hope all doubts are cleared, because he has taken all the aspect of TB program in a very brief and brief manner. And so, without wasting any time, I would share my slide and start my today's talk. So the topic which was given for today's webinar is invest to end TB, save lives, which is this year's World TB Day theme. So to just a brief about World TB Day. Every year we celebrate or observe this World TB Day on 24th March to raise public awareness about devastating health, social, and economic consequences of TB, and to step up the efforts to end the global TB epidemic. So very strategically, every year the theme global community identifies the theme, and it gets circulated to all over the globe so that that particular thematic area gets attention. So likewise, this year's theme is Invest to End TB for Saving Lives. So we already know TB is one of the deadliest infectious killer. Every day, almost 4,000 people loses their life due to TB, and around 28,000 people fall ill with this preventable and curable disease. This is very important. The disease is preventable and curable, but still we are struggling to fight this disease. Global effort to combat TB have saved an estimated 66 million lives since 2000, since year 2000. However, the COVID-19 pandemic has reversed years of progress made in the fight to end TB. For the first time in over a decade, TB deaths increased in 2020. So almost means if we invest properly, so we can get a returns. So the years of investment has saved almost 66 millions of since 2000, year 2000. So yeah. So as far as TB burden is concerned, so as per global TB report, almost quarter of the TB cases are in India. So whole of the world is looking at India. If we do right, if we tackle this problem in a right way, then the whole global curve will decline or will show decline. So India's contribution and India's strategies and for ending global TB epidemic is very crucial. Similarly, the problem of MDR TB is also there, and quarter of the cases, MDR TB cases, are from India only. And so India is a major player. Already Dr. Tripathy sir said ki, we have this, India is already committed for ending tuberculosis by 2025, which is 5 years ahead of SDG targets. SDG targets, SDG means Sustainable Development Goal. The goal is to end the global TB epidemic. That means less than 10 TB cases per lakh population. So as per NSP, Dr. Tripathy sir already said what are the various benchmarks which we have to achieve by 2025. So these key indicators, 3 major indicators: the reduction in number of TB deaths by 90%, reduction in TB incidence by 80%, and zero catastrophic cost. These are the 3 main targets of SDG, which has to be achieved by 2030. But India is committed to achieve these goals by 2025. So what is the progress so far? So as per the recent data which we have, the milestone which we need to achieve by 2020 was for TB incidence was around 20% decline, but what we have achieved up till now is just 11%. As far as TB deaths is concerned, the target up to 2025 was 35%, but what we have achieved is just 9.2%. And still 47% of people with TB faces catastrophic cost. That has to be zero from 2020 onwards. So we are, though we are on track, but still we are very much lagging behind. So these are the major pillars of National Strategic Plan. So I will not go in detail because it has already been covered. So what are the risk factors for infection? India has burden of tuberculosis infection globally. There are two things: TB disease and TB infection. So infection means the bacilli is there, but the disease is not there. So it is estimated that 35 to 40 crore Indian population is having TB infection, of which only 26 lakh are estimated to develop tuberculosis disease. So this is the huge burden, means the strategy which has evolved up till now, which the program is only diagnosing and treating tuberculosis cases. But now the strategy has evolved because we are moving towards ending TB. So we have to diagnose and treat TB infection cases as well. The number of the estimated number, which if we implement this strategy, then the estimated number or the cases which we need to find and treat would be around 30 to 40 crore. So we need to have a strategic plan for implementation of this new strategy. Means we have to go in a phase-wise manner, or we have to do the risk assessment. Those who are high risk will have to be prioritized and then move ahead. 5 to 10% of those infected will develop disease over the course of their life, usually within the first 2 years after initial infection. The risk of TB disease after infection depends on several factors, the most being immunological status. If our immunological status is good, then that infection will not break down into disease. The risk is increased almost 25 times amongst the contacts of bacteriologically confirmed TB patient compared to general population. 16 to 20 times in case of HIV co-infected patient, and 3 to 4 times in other immunocompromised status. So these are the high-risk groups which we need to focus while implementing this new strategy of diagnosing and treating TB infections. Regarding TB disease, we know the microbiologically confirmed untreated pulmonary TB cases can transmit disease to at least 10 to 15 people in a year and remain infectious for 2 to 3 years. Contacts of an active case are at 10 to 60 times higher risk of developing the disease. These are the few epidemiological factors which we need to consider while designing any strategy. There are some other determinants of tuberculosis like undernourishment, HIV, alcohol, smoking, diabetes. These are few factors, or these are few determinants which are fueling the existing TB epidemic. So we need to have a definite strategy for tackling these determinants as well, if we want to completely end the TB epidemic. So since we are sitting in Maharashtra, Dr. Tripathy sir has already given overview of global overview, Indian scenario. So since we are in Maharashtra, so I would just like to highlight these figures that nationally, almost whatever the target is there, almost 71 target has been achieved, and in Maharashtra, 74% of estimated TB cases were diagnosed and put on treatment in 2021, means last year. So Maharashtra almost contributes to 9% to 10% of total national TB burden. So if we consider this as an accurate estimate, then almost in 2021, in Maharashtra, we have missed almost 70,000 TB cases and almost 7,000 pediatric TB cases. So these missing cases includes public as well as private sector both. So this graph shows, these are all Maharashtra figures. Year-wise, first graph shows year-wise TB notification obviously in 2020 it has declined by 29%, and the obvious reason was COVID pandemic, but again it has started picking up. In 2021, Maharashtra has all diagnosed around 2 lakh TB cases. Similarly, for microbiological confirmation, from 2017 onwards, the microbiological confirmation rate of Maharashtra has increased, and obviously this suggests or corroborates that we are investing on rapid molecular testing. We are investing on increasing diagnostic facilities, may it be X-ray, may it be a microscopy center or a molecular diagnosis. So, or Maharashtra, we all are, since the program is investing on this particular component, so we could diagnose more and more cases, or we could confirm more and more cases microbiologically. So regarding pediatric TB notification, so this is a means as far as Maharashtra is concerned, and even nationally also, this figure is static. So a lot more need to be done in this aspect. As far as extrapulmonary tuberculosis cases detection is concerned, so the trend is increasing, but still we need to do we need to implement many other facility, or we need to invest more for diagnosing and diagnosing these extrapulmonary TB cases, because diagnosis of this pediatric and extrapulmonary pediatric cases needs special expertise, special investigations, which is not routinely available in our programmatic setup. So we need to have some specific or dedicated strategies. We need to have a linkages. We need to have linkages with private sector, private laboratories. We need to develop our public sector laboratories for diagnosing and treating such cases. We need to develop the capacity of our the ground workforce for detecting these cases. As far as success rate is concerned, so in 2020 it was around 88% for drug sensitive TB patient. For drug resistant TB patient also almost 95% detected cases were put on treatment. This is very important, this graph. As far as MDR TB outcomes are concerned, since 2012, you can see the blue patch on the bar, this diagram, bar diagram. So it is increasing. So over the period of time, the success rate has improved. Since in 2018 and 19, it has gone up to 55 to 50 and then 50%. So it has improved, but this is not sufficient. What we want is for drug resistant cases as well, around 75% success rate. But there are some challenges in diagnosing, treating, and then adherence is also a challenge. So we need to tackle this problem as well. As far as XDR TB is also concerned, so the success rate has improved, and obvious reason where the investment which the government of India or the global community has made in newer drugs, that has really improved our MDR as well as XDR success rate compared to the previous years. So this is just a comparative graph. Month-wise decline in TB notification in comparison to the COVID-19 pandemic. So there were COVID-19 first wave, second wave, and third wave. When this COVID-19 pandemic was at peak, the notification or TB notification has declined. So this pandemic has also given a major setback to the TB program. So key services which are available education, very important. Since years, since the program is launched, this strategy is there, contact tracing, but it has not been implemented as expected. So, but now is the time. If we don't implement this contact tracing properly and put these contacts on, screen this contact first, and eligible, if you don't put these eligible contacts on TPT, then we may not be able to achieve our goal. Likewise, testing for comorbidities, treatment adherence. The major challenge in TB treatment is adherence because of the long duration of treatment. So there are many studies and research are going on for reducing this treatment duration, and successfully in the case of MDR and XDR we have reduced the treatment duration. Previously the MDR XDR patient used to get treatment for around 2 years, but now it has been reduced to only 11 months. So naturally, because of this, the adherence will improve. So similar is the case for drug sensitive as well. 6 months of daily medicine. So the adherence is a challenge, and we need, adherence is a challenge, but if we strategize it, if we recognize this as a problem, and if we devise it, the strategies for ensuring the adherence, so then it is possible. Yes, nutritional assistance is already there in the program, and preventive measures. All these years we were only focusing on diagnosing and treating, but the prevention should come first. For any public health problem, prevention should be the first to think of. So now is the time. So we need to focus on preventive strategies as well. For diagnose, there are two approaches for diagnosing or finding TB cases in our program. So first is a passive approach, wherein the patient walks in, symptomatic patient walks into the OPD, and we use, as per the diagnostic algorithm, we use chest X-ray or the rapid molecular testing or microscopies for diagnosing this patient. And since last 2-3 years, we are focusing on this active TB case finding approach as well. So first one is intensified case finding, which means there are few high risk settings which wherein we have to screen all high risk patient for tuberculosis, like the diabetic clinic, the HIV clinic, the hypertension clinic, second is the active case finding in the vulnerable. We identify the vulnerable pockets in that community or that geography, and then we do the house-to-house search of TB cases. And also we need to remember, just active case finding without proper diagnostic planning, means without planning, will not help us. Means if we are going house to house, then we need to have an system to collect the samples, then process that samples on, give them X-ray and process that sample on appropriate technology, or let's say a rapid use of rapid molecular testing should be there. All this has to be planned in the active case finding approach. Also, only public health system cannot, only alone will not be able to do this Herculean task. So we need to involve other health program, other sector. We need to have a multi-sectoral approach for TB elimination. Private sector, sir already mentioned, Tripathy sir, ki almost 50% of our patients are in private sector. So we need to find those cases. There are mandatory notification clause for this. Each TB patient has to be notified to the government system. There is a gadget for that. If they notify, there is a incentive for that. If someone is not notifying, then there is a penal. The provision for penalization is also there. Schedule H1 implementation is again important thing. So Schedule H1 means all these drugs, TB drugs, are listed in a Schedule H1. Schedule H1 of whoever is selling this drug has to inform the or has to report the particular details of that drug, the doctor and the patient, to the government system. This will also give us an additional information or additional surveillance information for surveillance of these TB cases. So we need to implement these strategies as well. Again, to support this, the huge private sector is there. There are multiple challenges in implementation in public sector as well. We have a HR gap. Other challenges are there also in the public sector. So we need to involve the some agencies, public-private support agencies, which will bridge the gap between public and private. Because sometimes it happens. Means our approach should be a patient-centric approach. Suppose one patient is going to the private sector, that means he is willing to go there. So it should not happen, or our strategy should not be like that. Don't go to the public sector. Means don't go to public sector. Means don't. Means our strategy should be open. Na? So if the patient wants to go to private sector, then we have to provide all services at private sector only. It should not be like that the services are available only in public sector. Now you have to, if you want to get diagnosed and treat, then you have to come to public sector. So patient-centric approach is also very important. So this patient provider support agency, if we identify, then it can bridge the gap. So I told about the DBT schemes, the incentives are there. So there are multiple incentives under the program. So there are treatment support, and all these incentives are given through DBT, means directly to the beneficiary's account. So honorarium to treatment supporter is given for the provision of treatment supporter to TB patient for adherence, ADR monitoring and counseling. For drug sensitive patient, it is 1,000 rupees, and for drug resistant patient, it is 5,000 rupees. So this honorarium is given to treatment supporter. If the patient belongs to tribal area, then the travel support is given at the rate of 750 rupees per patient. The nutritional support at the rate of 500 rupees per month is given to the patient till the time he is taking treatment. And whether the patient is in public sector or private sector doesn't matter. So this barrier we have to remove. So incentive to private sector also, I have told, if the private practitioner is notifying any case, then the incentive of 500 rupees per TB case is given to that private practitioner. And if he is reporting that outcome of that patient to the program, then additional 500 rupees is also given. Informant, anyone can be informant, even your neighbor can be informant. If someone informs the TB patient to the public sector, and that patient, if that patient get diagnosed as a TB, then that informant is also eligible for this incentive of 500 rupees. So there are multiple provisions, and this all boils down to investments, where we are investing. And I have already told that many lives, 66 million lives have been saved. So if we invest in this program, then definitely we will going to get the returns. There subnational certification which has recently introduced. So we are means Government of India is giving bronze, silver, gold and TB free status to the districts and the states. It motivates them to go for this TB to intensify their activity. So community engagement, very important. TB forums have been TB forums at national, state, and district levels to provide the platform for all stakeholders, including the community, to voice their views. Has been established. So TB forums has been established where all stakeholder, all the community member can provide their inputs directly to the program. So this platform has also been created where community can directly demand to the program what they want. Even the TB patients or past TB patient, TB survivors are also the part of that community. They can directly demand to the administrator that we TB patient want this. So this platform has also been created by the program. Also, transformation of TB survivor to TB champion. This is a very good strategy. Those who have already suffered this disease are being identified as a TB champion, and now they are supporting this TB patients, existing TB patient. Engagement of existing community groups like PRI, self-help group, mass, youth club. So program is have a strategy, and we need to have a strategy for involving all these community groups for ending TB. Prevent. So there are 4-5 components in the prevent aspect. Airborne infection control. Sir has already taken everything in detail, so I will just enumerate this prevent strategies for prevention. Airborne infection control is the first. Then contact investigation, preventive treatment in high risk groups, management of latent TB infection, and address determinants of disease. So these are the few strategies where we need to invest more, because these are new strategies, and now our program need to move towards prevent. And so our investment in terms of man, money, material need to be there. So what are the key challenges which we face while implementing this, or while supporting the implementation of this program in Maharashtra, or let's say in India? Lack of, means this, why I am mentioning these key challenges, because you are the new generation having a touch for research as well. We can identify this challenge. We can focus your research on these challenges where we are struggling. So lack of stringent referral feedback mechanism, suboptimal involvement of private corporate sector in care of TB patient, reaching the unreached. There are slum, tribal, and vulnerable pockets are there where we are still not able to reach. So we need to have a strategies, or we need to come together to address this challenge. Drug-resistant TB, TB comorbidities, undernourishment, undernutrition, overcrowding, lack of awareness, and poor healthcare seeking behavior lead to delay in diagnosis. So recently, the last point, poor healthcare seeking behavior. So actually, this is an example. The TB prevalence survey recently, ICMR and Government of India has conducted TB prevalence survey, and this is this finding health seeking behavior of people. This is an additional yield of that survey, but it is an eye opener actually. The TB prevalence, recently conducted TB prevalence survey suggests that almost 63% of symptomatic TB patient, they do not seek care. So they have a symptom, means in that survey, 63% patient were having symptoms, but their health seeking behavior, they don't have health seeking behavior, means they did not approach any public or private sector for that symptoms. So they did not felt ki, this is a, means these are the symptoms, and I should go to the or I should approach doctor. So this suggests that we are lacking in awareness as well. So it is very important. So our people should know what are the signs, symptoms of TB, where to go, where to seek the treatment. So we need to focus on this ACSM aspect, advocacy, communication, and social mobilization in a bigger way. So, so this year's theme, that is invest to end TB and save lives. So you can see funding gaps. So means investment is just not a money, you know, investment should be man, money, material, everything. But when we say investment, so naturally what comes in our mind is money only, you know. So funding gaps impedes progress to end tuberculosis. So universal access to TB prevention, diagnosis, treatment, the investment which was expected was around 13 billion, but what we are investing is only globally is 5.3 billion. For TB research, we were expected to invest almost 2 billion, but what we are investing is just 901 million. You know? So we are almost investing, means half-hearted. Let's say there are multiple things, but we are not investing enough in the TB program globally. So invest to ensure access. COVID-19 has reversed progress in the fight against TB by over a decade. So almost we have got 10 years of setback in the program. So now is the time to invest to ensure access to essential TB services, including for TB and COVID diagnosis, to find and treat all TB patients. So invest in TB services. TB is the second top infectious killer in the world, with deaths increasing in 2020 for the first time in over a decade. There was a gradual decline, but in COVID, during COVID times, it has increased. So we need to invest in TB services to strengthen health system, pandemic preparedness, and end preventable deaths. We need to invest. Invest in enabling. Drug-resistant TB remains a public health crisis and a health security threat. So we need to invest in enabling access to WHO recommended fully oral 2 to 3 times shorter treatment regimen for better treatment outcome for people with drug-resistant TB. We need to invest to ensure access. Progress in enabling access to TB preventive treatment for millions in need fall far short. So we need to invest to ensure access to TB preventive treatment to stop TB infection from turning into disease. Global decline. Someone asked about whether the incidence is declining or not. The incidence is definitely declining, but with a very slow pace. The present decline is just around 2 to 3% annually, but what is needed is around 10% annually or more than that. So decline is there, but it is very slow decline. So our target or our end point is reaching. 2025 is our end point. So we cannot afford this rate of decline, and only 2% decline we cannot afford. So we need to invest on TB preventive treatment as well. This strategy will give us, if implemented properly, additional 8 to 9% decline is expected with proper implementation of this TB preventive treatment strategy. Invest to rule out. Overall, half of the children and adolescents with TB face barrier in accessing TB care due to difficulties in diagnosis and treatment. So we need to invest to roll out WHO recommended prevention, diagnosis, and treatment services for children and adolescents. Invest to empowering. Stigma. Still there is a stigma. Stigma deprives people with TB of their rights to quality care. So we need to invest in empowering those affected and stand in solidarity against stigma and discrimination. Invest in enabling. Undernutrition, poverty, as well as HIV, diabetes, tobacco are among the key drivers of the TB epidemic. So we need to invest in enabling collaboration, action, and accountability across sector to end TB. And finally, invest in TB research. We need to urgently close the investment gap to increase access to newer effective medicine, vaccines, and tools. So we need to invest in TB research and innovation to end TB. So thank you. More investment will save million more lives, accelerating the end of of the TB epidemic, to accelerate the end of TB epidemic. Thank you very much.
Thank you so much, Dr. Aniruddha. Indeed, bending the curve is the most difficult part, and we are on the verge of bending the curve because 2025 is approaching very, very fast, more than what we are expecting at that pace. So our efforts would have to be concentrated across what especially you have shared now, and I'm very much thankful for sharing these all concepts together to such a important audience with us. So there are some of the questions in the Q&A and some interesting comments in the chat also. So in the interest of time, I'll just take three, four questions, and I will read out one chat. That is from Dr. Aarti Nagarkar. Hello, ma'am. I know I have. It's a long time. For the point of epidemiological research, it would be interesting to see this new package of interventions have accelerated reduction of incidence cases as compared to the earlier RNTCP package of intervention. So this is point well taken, ma'am. There are some questions which I felt I could answer. Some of them I have kept it for the panelists also, for a real-time discussion. So some are very nice and open-ended questions, but some are very specific. I would take those which are very much specific for the panelists. The question is asked by Anushka Divakar. She says, what are the challenges and limitations of the new system of data management? So I would request Dr. Aniruddha if you can throw some light upon the new system of data management and the challenges he perceives.
So, data, as far as data management is concerned, so since beginning, when there was a paper-based system, and now it is a paperless system, but NTEP, previously RNTCP, now NTEP is considered to be the most robust program in terms of data. Now we have this online Nikshay software or case-based, web-based notification system, wherein a case-based data is there. And it is just not a notification platform. It is a patient management platform. Means people or the treating physician everything. This is a digital India, so program is almost moved to paperless system. Drug notification system, patient recording, reporting, everything is paperless. Drug logistic management is paperless. For that, Nikshay Aushadhi is the almost our census also suggests, and our routine survey also suggests that in the remotest part we have access to internet and computer. So there are some challenges, but that will be there. 5 to 10% or 5% challenges will always be there. But as far as digital data recording, reporting is concerned, I don't see any challenges, because over this year, our system of recording reporting has improved tremendously. So maybe Dr. Tripathi sir, if, may add to it.
Yes, I fully agree with you. Making this data available online, it makes central monitoring much easier. So what happens is the program managers have access to the data in real time. So they know very well what is happening to the patient's laboratory reports, what is happening to the adherence to the treatment, where drug resistance is more common, where the more effort needs to be put in place to address the issues of adherence and drug resistance. So definitely this has totally changed the scenario, because monitoring the program is a very crucial activity if we have to reach our targets, and where the targets are being met, where the targets are not being met, and what can we do in those places where the targets are not being met, so that that final goal will be able to achieve. So it definitely changes the whole scenario. Having everything on paper, analyzing data was very difficult. The only one suggestion I can think of, this Nikshay, if it can be made a little bit more user-friendly to analyze the data. Analysis of the data is not easy, because it gives a wide variety of information. But I think how do we make this data easily analyzable, so that something like a dashboard, so that all the time the data is coming on the screen and we know very well where there is a problem, so that action can be taken to address the issues where there is a problem. So maybe you can say a few words on that. Is there a dashboard where this data is available? Nikshay data, a summary of the data is available. And that if that is made available to all, both to researchers as well as to program managers as well as to public at large, that will it will be more transparency will be there, so that all will have access to the information, and then suggestions also can be given to the program also. Okay, and also queries can be given, like why there is a problem at some sites, why there is drug resistance more at some sites, why there are more number of cases at certain sites, what can be done to prevent. But finally at the end of the day, there is the issue of poverty. Poverty is a major driver of this TB indicators. So we have to also target and put measures in place. How can we put to place measures which can help these patients to earn more? Maybe some vocational training can be given, so that if they are, if a lady is a housewife, can she do something at home to increase the earning of her family? So something like that, if we can put in mechanism in place, so that they can come out of the poverty. So where there is poverty, how can we help these patients to come out of their poverty? How can we help them to earn more, a little more, so that they can, once their earning improves, their nutrition will also improve. their indoor pollution also will go away. Then their ventilation in their houses also, they will cater to that. Then like later one by one issues, if we can target, then the prevalence also in the long run will come down.
Thank
Prevalence
you so
and
much.
incidence.
I'll have 2-3 more questions. One which has come physically, and there are 2-3 which have come virtually, one by one. So there is one interesting question: are there special interventions for children with TB, as this is a major risk factor for for undernutrition? So I'll post it to Aniruddha, and maybe sir can contribute on that. Any special interventions for children?
Special interventions.
For children in TB.
Yes, definitely. Diagnosing pediatric TB case is a challenge. There are interventions planned in the program. Like first of all, in a big way, the program do not consider consider pediatric population as a separate thing. Program has devised NTP program has devised separate guideline for diagnosing and treating and managing these pediatric TB cases. First thing, separate diagnostic algorithm is there. The challenge in tackling this pediatric TB problem is diagnosing these TB patients. And why the diagnosis is difficult? Because there is a challenges in collection of the sample. Like adult population, pediatric population do not cough. So we need, and collecting cough sample is very easy, like in adult. But pediatric population, they do not cough. Also, their presentation is different. Always cough may not be the first symptom, or cough may not be there. Fever may be a or extrapulmonary site or lymph node may be the presentation. So treating physician need to be vigilant that he need to identify these signs and symptoms, and program also should have a facilities for building the capacity of their service provider, as well as collection of this sample and then testing them on appropriate diagnostic modality. So in Maharashtra, let's say the example of Maharashtra. In Maharashtra, we are routinely doing screening of NRC, means nutritional rehabilitation. Those children which are admitted in NRCs. Also, few facilities have been identified in public sector, or linkages have been identified. Few facilities have been developed where these samples can be collected. In private sector also, the hub and spoke model has been devised or developed, wherein at the hub hospital, these diagnostic sample collection and diagnosis facilities are available, and there are spokes wherein the samples or the patients are referred to that hub hospital. So in private sector, this hub and spoke model has been is also been implemented through public private support agencies. So we have means, but still the progress which we are expecting is not as expected. I have already earlier shown you the graph. The progress in notification of pediatric TB cases is almost static for last 5 years. The same is the situation in at national level also. So much more need to be done in this aspect. Sir, over to sir.
Yes, sir. Yes, sir. Thank you, sir. Thank you. Your comments are really helpful. Thank you. I just wanted to add a few lines. One is pregnancy and TB. That is something, when women who are pregnant, they develop TB. And then that is not detected in time. Then not only they develop TB, but they transmit the infection to the child after the child is born. So we have to ensure that program is in place, detect because pregnancy leads to some amount of immunosuppression, and especially if there's underlying malnutrition that can lead to TB in pregnancy. So if we ensure that during pregnancy the mother's nutrition is taken care of, she is screened for symptoms of TB, and at the earlier sign of TB detection, she is treated properly, then we can ensure that the infection doesn't get to the child when the child is born. Then there are, as pointed out by Dr. Kadu, sometimes it's difficult to make a diagnosis of TB in children. Like the children don't present with common symptoms of cough. So in that case, when the child presents with just fever and maybe loss of weight, then sometimes, and it's a child who's very small, maybe 2 years old or 3 years old or even 1 year old, then in such situation, what research has shown that if we put a nasogastric tube and collect the secretions and the next day from the tube, then that specimen is good for detection of TB bacillus, and also by molecular methods or by culture methods. Then the other issue is TB meningitis in children, especially a high degree of hello.
Sir, we can
Can you hear me now?
yes, sir. Yes.
Yeah. TB meningitis, a high degree of suspicion must be there, because if they are not detected in time, there's a high mortality. So in that case, collecting this, a degree of suspicion is there, should be there. The pediatrician should send the samples for TB testing and start the treatment as early as possible. Otherwise, the mortality will be high in these children. Then there are some studies which have come. In fact, there is a SHINE study where can we reduce the duration of anti-TB treatment in children who do not have extensive TB, where there is pulmonary involvement, but the extent of disease is less in the lungs. And we reduce from 6 months to shorter duration. Research is ongoing, and if that is successful, reduced duration will help in ensuring that the children are able to complete their treatment with good adherence. So these are some of my thoughts. I thought children, but I agree that we have to put in more efforts in detecting the pediatric TB cases to ensure that we don't lose these children. Your children are the future of the nation. We must give the best possible care.
Yes, and one more intervention which we are implementing since long is the chemoprophylaxis to pediatric contacts. You know? So since years together, but whenever there is a TB patient, our health staff goes to that house and he screen all the family members, and those children who are below 5 years, they are given this TPT, TB preventive therapy. but this strategy is there, but the implementation, yes, there are challenges. Even counseling part is also difficult because these are children. They do not have any signs or symptoms, and giving TPT for 6 months or INH or medicine to the normal healthy child for 6 months itself is a challenge. Means counseling or convincing the family member is also a challenge. So definitely the component is there since long, but the implementation part we need to further strengthen it. So this is another intervention which is there in the program, providing TPT to pediatric contacts.
Yes, thank you so much. We have already crossed a lot of time, and in the interest of time, we have taken up most of the questions. Some we have tried to answer virtually. Have typed down the responses of us, the panelists. Now we are coming at the fag end of this orientation program. So this has been an invigorating experience for all of us, and I am sure that we have a lot of to take from today's sessions and talks. And I now request Dr. Abhay Kudale from the Department of Health Sciences to express the vote of his thanks. Thank you for all the panelists from myself, and over to Dr. Abhay for the vote of thanks.
Yeah, audible. Yes. Okay, this webinar would not have been completed without first saluting our all TB, National TB Elimination Program staff members and frontline workers who are fighting tuberculosis almost 24/7 and in real sense contributing to NTP. And that is what is the global objective, and entire world is gearing towards that. First of all, let me thank Director of NIV, Dr. Priya Madam. Thanks are due to Dr. Shrikanth Tripathy, who is the former director and in charge of National Institute for Research in Tuberculosis. Special thanks to Dr. Aniruddha Kadu, sir, who is the WHO-NTEP team member. Many thanks to Dr. Kunal Pise from NIV for this welcome initiative. Lastly, our director, Dr. Aarti Nagarkar, and my colleagues at Department of Health Sciences. Thanks to all of them. Last but not least, thanks to all our students, NIV scientists, NIV MSc virology students, and all other important colleagues. We appeal all of you to keep on actually participating in all these webinars, and soon we are coming up with other webinar, and the announcement will be reaching to all of you soon. Thanks all of you. Thank you.
Thank you so much for participation. Just a last parting remark that ICMR is also being a part of the TB elimination programs, and it has been taking up around 35 districts across the country now from the central level with coordination with Central TB Division, Government of India, and ICMR headquarters. So thank you very much for everybody for participating wholeheartedly, and I wish everybody to have a nice day. Thank you very much.
Thank you. Thank you.